Good afternoon, everyone. On behalf of the Association of State and Territorial Health Officials, also known as ASTHO, I would like to thank you for participating in today's webinar entitled ASTHO's New Performance Dashboard, Measuring the Health of Your State Health Agency. My name is Joya Kaufman, and I am a senior analyst of performance improvement at ASTHO, and I will be moderating today's session and providing some information at the end. This webinar is the fourth in a series of webinars around the topic of accreditation and quality improvement. Today's webinar is brought to you through funding and partnership between ASTHO and the Centers for Disease Control and Prevention, Office of State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. The concept of an agency dashboard is not new. However, using a dashboard to determine the operational health of a state health agency is a relatively new concept. Our objectives for today's webinar, as you can see on the screen, is to provide the purpose of the performance dashboard and a brief description of performance management systems. We will also describe the linkage between the performance dashboard and your state health agency's performance management system and agency-wide quality improvement activities. At the conclusion of the webinar, you will be directed to a link to answer a few questions on how well we have met those objectives. In the spirit of our own quality improvement, we very much value your feedback, so please take a few moments to complete the evaluation. So we are very excited to bring you today's webinar, and based on what I can see, we have about 60 people on the line, and so we look forward to a robust Q&A at the end of the session after the presenters speak. So if I could take a moment to orient you to ReadyTalk's platform, there are two ways in which you can submit your questions. The first is through the chat function located on the lower left corner of your screen. You can submit questions at any time throughout the presentation using this function. Your second option is to hold your questions until the end of the presentation, at which time the operator will open up the line and he or she will ask you to ask your question. So, at this time, I am pleased to introduce our guest speaker and subject matter expert, Les Beitsch. So I'll share a little bit of his background. Many of you probably know Les. He joined the faculty at the Florida State University College of Medicine in November of 2003 as a professor of health policy and director of the Center for Medicine and Public Health. Before joining FSU, Dr. Beitsch was the commissioner of the Oklahoma State Department of Health. He also served as a deputy secretary and assistant state health officer for the Florida Department of Health from 1997 to 2001. Before this appointment, Dr. Beitsch was assistant state health officer and division director for Family Health Services and medical director of the Broward County Health Department in Fort Lauderdale. Currently, Dr. Beitsch serves on ASTHO's Performance Policy Committee and also serves on the advisor group for the Performance Dashboard Project. So, without further ado, I will hand it over to Dr. Les Beitsch.
Thank you, Joya. I appreciate that in the introduction. And looking at our list of attendees, I think we have several people who could be giving this presentation, so we can hopefully hear from them during the Q&A session and gather all their nuggets of wisdom that they can share with us. And so just starting off, the performance management system, the whole point of it is to give us a sense of how well we're doing as an organization. And so that's how I've titled this session. Many of you can see, hopefully, that this is a Mobius ribbon or loop, which I have appropriated from my colleague Jack Moran at Public Health Foundation. I see without proper attribution. So now you all know it came from Jack. And the idea around this Mobius loop is that quality improvement is a continuous process, first of all, but second, that it takes place at multiple levels. For example, there is quality improvement at the individual level. The individual employee at the Department of Health or in the local health department has their own job description, and everyone should be striving to do that role better and wants to do that job better, so they have their own individual quality improvement plan. The quality improvement that I think most of us are more familiar with, though, is quality improvement at the programmatic level. And so whatever program or organization within the health department that you're working in, you've got goals and metrics and other things that you can build performance improvement, quality improvement programs around. We frequently call that little QI, and we can apply a number of quality improvement tools to that. As you can see in this diagram, Lean Six Sigma, Rapid Cycle Improvement, and so on are just two approaches that you can take to do quality improvement within your organization. Then thirdly, where you see in the rectangle turning point or Baldrige, you see big QI. And that's around performance management or macro QI. That's looking across the entire enterprise to manage performance for the organization. And let's say that you're part of a larger health and human service organization or part of a region. You may be working with other organizations and you may have a meso quality improvement where you're working in collaboration with others. So at least 4 levels to think about. We're going to spend most of our time here briefly talking about big QI, and again, harnessing the ability to manage and improve performance across the entire organization. So I think many of you are familiar that with FAB Standards and Measures, and of course FAB is the Public Health Accreditation Board, and FAB is the accrediting body around the National Voluntary Health Department accreditation system that's in place. And I think you all are familiar that the FAB Standards and Measures are around 12 domains, and Domain 9 is around evaluation and quality improvement. Standard 9.1 in particular, which I'm showing you, it's probably a little bit small print to be able to read, and I'm not going to read it to you so much as to suggest that it's important at FAB and as an organization that there be a performance management system in place, and that you be able to document and demonstrate in your submissions that you have performance management systems in place within your public health organization. And even I think we've been able to recognize at FAB and elsewhere that this is one of the areas that many health departments are new to. They're in strengthening and enhancing their capacity, but it's a relatively new area, and there's an opportunity then to learn more from one another in this particular area. So this is a verb I invented, and so if you ever look me up in Wikipedia, it would give me full credit for inventing the term desiloifying. And that may, in fact, be my only claim to fame. Desiloifying is what performance management is actually all about, and it's also really what's trying to be accomplished through the FAB Standards and Measures, of course, looking across, again, the entire organization or enterprise. So if I was to show you the Mobius ribbon or loop again, you would be thinking about in little QI, the programmatic QI, you'd have quality improvement activities taking place within each of these silos. And of course, that silo could represent activities at the local, state, federal, tribal, and territorial level, if you will. But when we're talking about managing performance and how well we're doing across an entire organization, we aren't focused on those individual silos. We're looking at ways of measuring performance that cut across all of those programmatic areas within our organization. I want to share with you a slide that came out absolutely terrible. I don't know what happened here. This has been borrowed from the balanced scorecard system, and I think it's a color issue. So I can use whatever numbers I want since you can't read them. The vision barrier, first of all, that looks black to you. What it should say in that box is that only 5% of the workforce understand the strategy. So if you have an organizational strategic plan, and it's important within that organization for members of the organization to contribute to achieving the outcomes described in that strategy and strategic plan, if only 5% of the workforce are aware of those strategies, you're not likely to achieve them. The management barrier, circled in red, says that 85% of executive teams spend less than an hour per month discussing strategy. And think about it, if you will, in your own organizations, in your own experience, that often we're dealing with the tyranny of the immediate, trying to resolve a crisis as it's occurring, rather than spending valuable leadership time mapping out the future that you want to create. And finally there, I'm going to talk about then the other box in red, which is a resource barrier, which says 60% of organizations don't link budgets to strategy. Let me back up and say that, and I've said this frequently, and hopefully you all are better managers than I've been in my career, but we're going to do this without resources, which this is important enough we want to get it done. And yet if nothing is specifically a budget priority, that you haven't allocated resources to it, then what you're making very clear to those people who work in the organization is that it's not in actuality a priority. So the budget should align very well with the strategies and the priorities you set as an organization. And as you can see just from the ones that I have mapped out for you, that typically that's not the case in most organizations. And so there's some real opportunities there. What I want to share with you now, and I think it's something many of you, if not most of you, are familiar with, this is the Turning Point Performance Management Model. And it's presented in 4 quadrants. And this was first shared in 2003. And it was released specifically as a developed public health performance management model. And it was part of the Turning Point project funded by Robert Wood Johnson and also the Kellogg Foundation. And it was part of a Performance Management Excellence Collaborative that 7 states participated in, a number of national organizations, and I was privileged to represent ASTHO on this particular work group. I bet you didn't know that, Joya. And so they came up with, again, these 4 components in each quadrant. And what's remarkable there is performance standards, at the time this was released and really the development phase that preceded its release, there weren't any universally accepted performance standards. The good news for us now is we've had several standards proposed since then. There were the National Public Health Performance Standards, and now I would argue that the FAB Standards and Measures are a national public health standard that you might employ, and hopefully you will employ. Performance measures, and again I would point to maybe the metrics within the FAB system, but you've got standards. What are the indicators that represent achievement of those standards? But you've also got a lot of things in federal grants and other places that give you benchmarks to look at. You've got strategic plans of your own that require you to hit certain metrics, and so you want to be able to measure those things. Thirdly, there's a reporting of progress. It's how do you share with others how your organization is doing, and do you do it in a periodic way? And so having that data and sharing it in some sort of regular way. In 2003, relatively few states and locals had web capacity to do that, and of course that's now something that's remarkably available. And then finally, in quadrant 4 is that little QI piece. It's taking all of the information from standards and measures and focusing in then on those areas that are most important to have quality improvement projects around. And I'm probably going to belabor this, but you don't want to do a quality improvement project on everything. And in my career, of course, I've not necessarily always realized that. But you want the quality improvement projects to be dedicated to things that are priorities for your organization. So that's the model from 2003. So fast forward a decade, and Public Health Foundation, with some support from the Centers for Disease Control and Prevention, wanted to update and refresh the Turning Point Performance Management System. And they went through a rather arduous process to do that, which I'm not going to go into at the moment. But I don't think you can have 5 quadrants. So we had to move from calling them quadrants to components now. And so you see the ones in the middle look remarkably similar to the ones that were part of the 2003 model. What was added, though, is critically important as well, and that is the whole notion of the role that leadership plays. And while that seemed implicit to us in 2003, it became more important for it to be explicit. And along with visible leadership are some sort of subcomponents that are listed here on the rims of the diagram that are really pretty important. One is the culture of quality. So the culture is established as a role that leadership plays. And so, culture is how you do things within your organization, and leadership sets that tone. Leadership also helps make the decision about whether you're going to have a customer focus within your organization and help you define who your customers in fact actually are. The great thing about being in a public health agency, we know at least some of our customers are the residents in our jurisdiction, whether again it be state, local, tribal, territorial. There are customers, but we may have other customers as well. And finally is the issue of, there's the issue of transparency and openness. That's about building trust within the organization and accountability, because we are public organizations. But the issue of strategic alignment, that it's up to leadership to examine all the things that your organization is doing. I'm thinking about a community health assessment or a state health assessment, a community health improvement plan or a state health improvement plan, and then the organizational strategic plan. Those things should align together in a very thoughtful, deliberate, intentional way. That is a very important role that leadership plays. So there are lots of other performance management models out there. Again, Turning Point being one designed specifically for public health. I am a huge fan of Baldrige as another approach. I shared with you Balanced Scorecard a little earlier. That's likewise a great performance management model that many states have used and many health departments, but also many organizations in other sectors have. Baldrige has been around for I guess about 35 years now. And it's a model with really 7 critical dimensions to it. And you see there that in this diagram that it has leadership, strategic planning, customer and market focus, a workforce focus in HR, process management around quality improvement, and finally business results. And cutting across that are information and analysis. It has most of the same things that we discussed or that I just presented to you with the Turning Point model, but it's very explicit about how these pieces fit together. And this model works very well for public health. And one of the reasons I like Baldrige so much is it's a public domain model. The tools and technical assistance and other things are available at relatively low cost because almost all of the 50 states each have their own Baldrige program. In Florida, we call it Sterling. In Illinois, for example, it's called Lincoln. I think that's probably a pretty good name for it. And so each state has their own particular approach, but the basic model itself for Baldrige remains the same. So that's another thing to consider. And again, so what would the business results be for public health? It would be health outcomes that we're trying to achieve in our jurisdictions. So, and our progress toward doing that. And I should mention, we used Baldrige and components of Baldrige quite extensively in Florida, both during the time that I was there and afterwards. And this diagram is from, this blue home plate diagram is from a paper some colleagues from the Florida Department of Health and I did well over a decade ago. And I use this slide not because it's up to date, because you can see it has Healthy People 2000 and 2010 benchmarks, so it does date it a bit. But rather, I use this slide to remind me about the importance of alignment. I mentioned that a bit with the new Turning Point Performance Management Model. You see it built in explicitly in Baldrige. But here, what you see in each of those boxes are some mutually reinforcing efforts that were going on around all the activities that we were doing as a state health department in Florida at that time. So we tried to align the mission and vision with performance standards at the state and local level, the needs assessment. They were consistent with federal grant requirements and our quarterly performance measures and individual program plans and so on. So think alignment, if you will. Now this is something, and I think we've got a couple folks from FAB on this call. I borrowed their strategic map for just a moment, just to let you know that there are other ways of doing strategic planning and making sure things are in alignment. And one of them is to do something like a strategic map, which is a representation often of a strategic plan, really on a one-page document. So here, the goal for FAB here, the ultimate sort of what were we trying to accomplish, was to successfully deliver and promote the value of FAB accreditation. And you can see there A, B, C, D, and E represent substantial tracks of work that are involved in trying to, well, sub-goals really, in trying to meet that overall goal of successfully delivering and promoting the value of FAB accreditation. So I wanted to share that with you. So I think what you can probably also see is this looks a lot like a dashboard from your Escalade that all of you drove to work today. It's a car dashboard, and when you think about it, what's a car dashboard about? Car dashboard is to tell you, while you're cruising on your way into work, how your enterprise, in this case your car, is doing. So you can look at all those gauges and get a sense of whether you're going to actually successfully arrive at work based on the health of your enterprise, in this case your car. Doesn't necessarily tell you about what's going on externally, doesn't tell you how safe the road is, how traffic is, but it tells you how your car is doing. But it doesn't tell you necessarily what individual parts are doing. For example, if while you're cruising down the road, the engine light comes on, well, there are hundreds, if not thousands, of parts in the engine. That becomes something that raises the question of the engine. There's something there that needs some further information to inform us about how our engine is performing. But it lets us know that there's an area that we need to drill down in a little bit deeper and gather more information. So in essence, and this is another dashboard, this is obviously not a car dashboard, but it's again an organization looking at, in this case, about 7 or 8 different areas within this organization to develop its overall health. Many people do dashboards with green, yellow, red kind of colors, or a whole host of things, and you see some different colors and pie charts and things deployed here. But the purpose of the dashboard and the purpose of the ASTHO dashboard, which Joy is going to discuss here a little bit in just a moment, is to give you a sense of the health of the enterprise. And in this case, we're talking about the health of the state health agency and what are some areas that we might begin to look at a very high level, develop some indicators that can tell us something about this going on there, and if those indicators have a yellow or red light equivalent for us, tell us that we need to gather a little bit more information and drill down. So I'm going to stop there and turn it over to Joya.
Well, thank you, Les. We appreciate you providing an overview of performance management and its purpose and importance in public health, and that segues nicely into this next portion, which is going to talk a little bit more in depth about the ASTHO performance dashboard, which Les was very involved during the development of. We hope he remains involved and gives us his wisdom. So Les, I might throw some questions your way at the end, but as Les said, there's performance management, and each state health agency might have their own performance management system, but ASTHO has moved forward with developing a performance dashboard that's intended to be perhaps a tool in your toolbox. So not to fulfill the performance management requirements for FAB, but perhaps some of the indicators that we're proposing to include could be on your agency's performance dashboard. Okay, so just to give a little bit of background, ASTHO has several policy committees that are interdisciplinary and have state health officials and senior deputies from different agencies to help kind of drive the direction that ASTHO moves forward with public health policy. So we have a performance policy committee that has experts and leaders from the performance and quality areas, survey research, evaluation, and workforce. And each year we bring together the committee to set forth priorities for the year. So as you can see on this slide, one of the priorities that the Performance Policy Committee had for the end of 2012 through 2013 was to develop a dashboard of business process performance measures for state and territorial health agencies. And the Performance Policy Committee came to this conclusion after a long discussion about accountability and measuring health, but there was also conversation about how there are a lot of dashboards in the field of public health, but not many that had to do with health outcomes, but not that had to do with the agency. And so it kind of goes back to that old saying, if you've seen one state health agency, you've seen one state health agency. So the committee wanted to try to put together a dashboard that would be able to align different indicators across all state health agencies. So at the Performance Policy Committee meeting in 2012, at the end of 2012, we asked the participants to do an exercise that had stickies to suggest if you did have a dashboard that had performance measures of business processes or administrative indicators, what kind would you like to see on that dashboard? So different members came up with ideas such as the number of days or reworks for internal processing of contracts, days from invoice receipt to payment, hiring time, vital records processing time, revenue versus expenditures, etc. So while this does not have to do with the health of your population, it does have to do with how well your agency runs, which ultimately affects how well you're able to deliver public health services. So if you'll see the action steps, the committee decided on 4, and the first was to develop criteria for selecting measures, to select and operationalize the measures, and then to developed some supporting materials for the dashboard, which would include a companion guide, a quality improvement companion guide, a FAB crosswalk, as well as a data dictionary. And the last step would be to pilot test the prototype of the dashboard. So on your screen now you can see the purpose and goals of the dashboard. I kind of went over this earlier, but the intention is for the dashboard to be used as a tool that alerts executive management and or state health officials and leaders about problems. So just as Les mentioned a few minutes ago, the dashboard isn't going to tell you exactly what your problem is. If you have an indicator that says check engine, it could be several issues, but the purpose of the dashboard is kind of be a flag and say, hey, you have an issue. It's also important to notice here that it says for executive management and state and territorial health leaders. So what you will find on the ASTHO performance dashboard is that there are a limited amount of indicators that would be important to a state health official or a senior deputy or a CFO. So there won't be 1,000 HR measures because this is not just for your HR director, but these are the most important issues that your show or a leader would really be interested in knowing about. Second, the purpose is that the dashboard should be used as an agency resource that is supported by data. Several people on the committee have mentioned that they would like to use this information to go to their governor or their legislature, and that ultimately it would serve as a catalyst for quality improvement. So it's not just for the purpose of knowing, but for improving. The dashboard is also meant to utilize dynamic data that can be measured frequently. So the committee didn't feel that it would be important to have indicators with data that would just change once a year. The data should be something that can change frequently and that we can have an impact on, so if we do make improvements, we can see it reflected in the dashboard. And lastly, the dashboard should be aligned with other initiatives and indicators. So the purpose would not be to have another dashboard with new information that couldn't be applied elsewhere, but a dashboard that aligns with the FAB Standards and Measures, funds, and other common state and territorial health agency measures. So we look to the committee to provide us guidance during this process, and as you see, the members were Dr. Ronald Chapman, who is the state health official from California, Steve Runk, who's the senior deputy in Oklahoma, Joanne Ashheim, who is the performance improvement manager in Connecticut, Les, who is on the call with us today, and Paul Halverson, who is most recently the state health official in Arkansas. And so they really led the way with where we were supposed to go in terms of the direction of this dashboard. They played a critical role in setting the strategic goals, identifying resources, and selecting indicators, and reviewing and refining supporting materials. So just right here you can see quickly there's a timeline of when we wanted to complete certain deliverables. But what I wanted to get into next is what are the types of indicators on this dashboard, and how do we come to identify them? So ASTHO realized that we didn't quite have the capacity to do a really thorough environmental scan, but we did realize that we did want to survey what was out in the field rather than to develop new indicators. So we contracted with a consulting agency to help us to develop the performance dashboard. And so our goal was to select 10 to 20 key indicators and 10 to 20 optional indicators. And a little later on, I will go over the differences between the key and the optional. And again, the dashboard indicators are meant to allow for a meaningful comparison across organizations, so comparing apples to apples, to facilitate the collection of data, and to have comparable indicators between the state health agencies. So we really want it to be so that California can compare to Maine, can compare to Texas, because they're all measuring the same thing. So to do this, we did an environmental scan again, it was important that we didn't go and create new indicators, but to see exactly what states are currently measuring to give a feel for what we should be including on the dashboard. I see some people on the call right now that I probably reached out to collect and measure scores, so I appreciate your input and guidance. All in all, 78 resources were reviewed to establish a baseline of current indicators. We also did some keyword searches and reached out to people in state health agencies. So for the environmental scan, there were 20 resources from state health agencies that provided applicable indicators. And this means that they were business process or administrative indicators. There are about 20 states that did not have indicators that applied to this dashboard, which doesn't mean they didn't have performance indicators, but they were perhaps of a health outcomes nature, or maybe they were specific to their agency, so that wouldn't really apply to the ASTHO dashboard. So we had about 386 potential indicators, which is quite a lot, and they aligned with about 11 categories that you see before you. So at this time, we engaged, well, first, ASTHO and ICF worked together to kind of cull down the indicators internally before we brought it to the full committee, well, to the subcommittee. And we were able to come up with 136 indicators that we were going to present to the subcommittee. We removed some duplication, and we again looked for, was this relevant to our dashboard, and could it be applied to most state health agencies. In June of 2013, we had an in-person meeting at ASTHO where the subcommittee met, and the goal was to cull even further the list down to 50 indicators. So on the screen, you'll see 4 different criteria that the subcommittee was to consider. The first is that it was critical to the operation of a state or territorial health agency. The indicator was important at a state health official or senior deputy level and allowed him or her to make high-level decisions. Again, broad applicability across state and territorial health departments. And again, the data is dynamic and changes at least monthly. Now that would change later on down the road because we did find that some things were very, very important. However, they did not change monthly. And so what you'll see here is just a few pictures of this process, which I thought was a bit fun. I think the participants did too. Hopefully Les will agree because he was there. But we used a large sticky wall to group the different indicators and move them around based on feedback from the participants. So on site, there was also a new realm of indicators, a new realm of criteria. And so the first is that the data was readily available and could be retrievable without undue burden, that the indicator allowed for comparability and benchmarking, and that it allowed a user to identify areas for further investigation. And so that, again, goes back to that red flag. We don't just need to know there's a problem. We need to know where we can go in order to identify that problem and to improve. The indicator requires frequent interaction and analysis, and the indicator has a data source that allows for frequent update. So we were able to get the indicators down to 50, and what we were able to do was put them into 8 different categories because we did collapse a few. So the categories ended up being customer service, data accuracy and quality, financial management, grants and contracting, human capital, information services and technology, program development, and process improvement. And so what I will do quickly is give a little bit of an overview of the kinds of indicators. So we had 21 key indicators, An example of a key indicator would be, for example, in the area of customer satisfaction, the percentage of health department programs conducting a systematic process to assess external customer satisfaction and address complaints reported quarterly. We had in financial management the average number of days for a health department to pay invoices. In human capital, the proportion of authorized health department staff positions filled reported quarterly. And in program development, the percentage of health department programs that annually utilize performance targets and performance measures reported annually. So for key indicators, we felt as though this would be something that every state health agency should and could be doing as it stands today. The subcommittee also identified optional indicators, and we realized that not all health departments have data sources, or they may not be able to, or not all indicators would be applicable to their agency. So those were some of the criteria for having an optional indicator. Some examples include average number of days for the health department staff to process citizens' requests for health documentation, for example, a birth certificate, or the percentage of health department high priority requests for IT service that are resolved on the same day, reported monthly. And lastly, the percentage of health department programs using a proven quality improvement model, reported annually. And then the subcommittee came up with another category, which would be a developmental indicator. So this a developmental indicator would be one that needs to be fleshed out a lot more, but this is still an area that is of importance within a state health agency. An example would be the percentage of health department programs whose employees' performance evaluations were completed on time, reported annually. So we know this is an area that several state health agencies, or just companies in general, have a little bit of difficulty with, but it's still important and is actually a little bit of a component of the FAB Standards and Measures. And for information services and technology, we had two developmental indicators. The first being the presence or absence of health department chief informatics officer, and the presence or absence of a health department informatics strategy. So we know not all health departments are there, but those are some example developmental indicators to reach for. And so we are also in the process of developing a data dictionary, which is actually extremely important to the indicators because, as you'll see on the screen, they will provide the specific measurement specifications, the indicator origin, why the indicator is useful, its alignment to the FAB Standards and Measures, the data source, and the operational definition. And this is so critical because it ensures that a person that's using the dashboard is measuring the same thing that another user in another state might be using. So everyone is on the same page. So every indicator has information that you see before you. We're also developing a quality improvement companion guide, which is also kind of meant to be a user guide. So it's taking, okay, now I have these set of indicators. How do I use them? And even furthermore, how do I use them to implement quality improvement? So it's not just knowing, well, maybe you're doing poorly in an area, but what can you do to improve? And again, the FAB crosswalk is important to us because we want to be able to show that this is aligning with other performance indicators in the field. So just wrapping up, next steps. So this performance dashboard is intended to be an ongoing process. We like to consider this phase 1. So this was our environmental scan and our research. But moving forward, we do want to refine the indicators. We do want to pilot test the indicators, potentially with 4 to 5 state health agencies. We anticipate that the different sites will provide quantitative and qualitative feedback and overall the utility of this dashboard within public health. So We want to make sure that this is going to be useful to state health agencies before rolling it out into the field. We would probably also expect to capture information such as how long did it take you to retrieve this information? Were there information systems that you relied on to get the data? Did we ask the right questions? Are the right indicators here, or should we try again? And we would also be asking, do you have any ideas for potential new indicators? We are envisioning that a senior deputy, a CFO, or a SHO would be involved in this process, and that it would probably be 6 months, and we'd ask them to do different evaluations and really provide feedback on what it's like to go through obtaining the information for the dashboard and making sure that we have the right content there. So we look forward to that next phase of the dashboard. So I know that was quite a bit of information, but what we'd like to do at this time is open up the lines for Q&A. We welcome any questions that you have about Les's portion or my portion. This is really an opportunity for you to get a better understanding of the dashboard, perhaps provide input, or ask any questions you like. So at this time, we'd like to please open up the lines for Q&A. You can also submit a question through the chat feature, which is in the lower left corner of your screen.
Thank you. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. You may also send your question using the chat feature located in the lower left corner of your screen. One moment, please, for the first question. Ladies and gentlemen, as a reminder, to register for a question, please press the 1 followed by the 4 on your telephone keypad. One moment, please.
Well, we have a few questions coming in through the chat while others are potentially thinking of their questions. So I'll go ahead and get started with the chat question. The first is, please provide examples or details of how you envision ASTHO indicators being used as a part of a broader performance management system. So I propose, I guess Les or I could answer the question. Les, do you have any ideas about how, since you're on the subcommittee, how you can envision ASTHO indicators being used as a part of a broader performance management system?
Yeah, and I see this question comes from Paul Epstein. Paul, I hope you're doing well. And Paul is, of course, extremely knowledgeable in this area. And Paul, I would suggest that this is just one of many systems in place. I would think that one of the roles that the senior executive management team, leadership team of the organization has is they meet regularly and go over a lot of things about the status of organizational performance. This is one of those areas where they might look at weekly or monthly, and as you heard Joy say, some of these don't lend themselves to monthly updates, but it's a regular place that management can check in, during a regularly agended meeting, each time they gather and say, how are we doing? And somebody should be responsible for checking it, and the management should share that. And then if you have again, that green light, yellow light, red light thing, if everything is green, you might not spend a lot of time on that topic during that meeting. But if something is red, it's very likely that a member of the management team might be assigned to do a little bit digging in that area and share with management a little bit later. So I would view it as being one of many tools, but one that can be used most regularly. Again, just like when you're hopping in your car and you're driving to work, it's just a quick glance tells you right away that, yeah, all the major systems of my car are working. Wish I had added gas.
Thank you, Les. We have another question in the chat. Does ASTHO think at some point that the outcome of this work could be used to update the measures for FAB accreditation? And I'll take a stab at that one. I do believe that this will be really important work in informing the FAB standards and measures, because some of the, actually most of the indicators here do align with the standards and measures. I think that the information that we receive from the pilot test could be shared with FAB, and perhaps we could engage them in that process to get some feedback on the FAB standards and measures. So we do welcome that opportunity to update the FAB standards and measures. Do you have any thoughts on that?
The only thing I would add is, and again, Joy did a nice job of showing how this has been crosswalked, but one of the ongoing issues around standards and measures for accreditation is that we're measuring the right things. And so this dashboard, part of the feedback that's going to come from the pilot, are these the things that we need to be looking at to tell us about the health of the organization? I think there's a lot of overlap between the kind of information FAB would want to have to know they're measuring the right things of high-performing organizations.
Thank you, Ed. Susie, did we have any questions come through the audio?
There are no questions at this time from the phone lines.
Okay. Well, we still do have a few chat questions. So the next is directed to you, Les. Dr. Beich, could you go over the barriers again?
Yeah, I was looking at that question. I'm trying to think when I actually went over the barriers at all. So if I was going to slip back to some of the slides there, if we went back to the Mobius diagram, or even the de-siloifying diagram, perhaps, Dave, I think that's a great question. The tendency in many organizations, and quite frankly, I have done this many times myself, so I am not casting aspersions on others about sins I have also committed, is that we tend to get very focused on our silos. So that's, if you're thinking about your entire enterprise, you can't just be focused on silos. Secondly is the issue for me around allowing 1,000 flowers to bloom. And, we want everyone working in a public health agency to have some basic quality improvement skills. And over time, I think we want them to have advanced skills. But everything that we do in public health shouldn't become a quality improvement project. And the things that we should be doing and expending those scarce quality improvement resources around are things that are aligned with our key organizational priorities. So, when I'm thinking about obstacles, I'm thinking about this alignment issue, which I think is so crucial. And quite frankly, we in Florida, in the late 90s, discovered that more serendipitously than by thought. But once we figured it out, it became a rather intentional act for us. So all of those things are just a handful of the many obstacles. Not making your strategic investments by placing in budget those things that you think are important, and for all the people in your organization to know that what your key strategies are. And Dave, I know that you all do that very well in your state in terms of sharing what your key strategic objectives for your organization is trying to achieve. And I think others should do that as well.
Thank you, Les. Susie, do we have any phone questions?
There are no questions at this time.
Okay, well, we do have some more chat questions rolling in. So the next question is, what will be the final format of the dashboard? Will it be in an electronic format? And so I will take the first stab at answering that question. I think at this time it's unknown what the final format will look like. It's actually a really loaded and kind of complex question. I think that moving forward we'll be looking to the pilot test as well as the subcommittee and state health agency leaders to see what they feel is the most appropriate final format for the dashboard. We do want to use this tool for comparability and goal setting and benchmarking, but we do know that has some specific implications. If that data is housed on a server that's accessible, will it be used negatively, not for improvement, but to kind of show if states are not doing well in an area? So I think that there needs to be a lot more research and input to guide where we plan to go with the dashboard, and we do plan to do our due diligence to identify the best way, but also recognizing that if it just sits at each state health agency, you may think it may take one agency 45 days to process a contract, and then it might take another agency 3 months. So without communicating those two parties or several state health agencies, how will we know what's optimum performance? So I think we're going to be feeling our way through the final format of the dashboard. Any input there, Les?
The only input that I would have there is again the reminder that this is a menu, so there'll be some things that are common to states, but since states have differing priorities, the opportunity to customize what the dashboard looks like in your state remains. So it'll ultimately be quite a flexible tool.
Yeah. And then I have another question about, is the pilot test open to volunteers? How do we let ASTHO know if we are interested? I'm so glad you asked that question. So probably towards the end of the year, ASTHO will have this pilot test open, and we will be selecting participants. I don't think that we've finalized the process of selection, but it will be open, and we're looking to define who we want to engage at the state health agency, since this is meant to be a tool for executive leaders like SHOs and senior deputies. But we also recognize that staff such as the performance improvement manager or the HR director might have the most access to this type of data. So the pilot test will be open to volunteers. We're likely looking 4 to 5 at the end of 2013. Oh, and how do you let ASTHO know if you're interested? Well, you could contact me, Joya Kaufman, and we will also be sending communication once we've decided upon the process and the full scope of the pilot test.
Joya, before we sign off, there's one last question there that I think is worth mentioning at the end, if you could.
Yes. Oh, sorry. I thought you were going to read it since you brought it up. Okay, I'll read it. Is it will this tool interact? Is that the question?
Yes, it is.
Okay. All right. Well, I guess we'll just call this the last question since we are coming on 2:30, and we don't want to hold you all too long. But the question is, will this tool interact with the proposed CDC Prevention Status Reports state report cards? It seems like the indicators on those draft reports would match well with this tool. Well, I will answer this a little bit, and then I'll let you answer as well, Les. I do have some experience working with the PSRs. I do think that a lot of the indicators there are about strategy and about health outcomes, but more about the programs that are aligning with the health outcomes. So I think that's an area that we could look into. I'm not sure at this time how well this dashboard will lend itself to the PSRs, but I think that that's something that we can look into and perhaps include in the pilot test.
I think that's a great answer, and what I would add to that, Lindsay, is that I think they actually complement one another pretty well. And if you're thinking about, what you might look like for a whole series of a well-developed system, it would pretty much follow a logic model building from capacity and process all the way out to outcomes. And so the CDC is a little bit further along. Some of the dashboard things are more about capacity and some about process right now. So I think they would work well together.
All right. Well, it's about 2:31 on my end, and unfortunately it seems that we are out of time. So again, I just want to thank everyone for participating today. I hope that the information is helpful. I definitely want to thank Les Beich for presenting and sharing with us today and for fielding questions for those on the call. Again, if you are in need of further information, please do contact me. My information is on the screen. We value your feedback, and please take a few moments at the end of the webinar to provide feedback on a survey. Thank you, and that concludes today's session. Please have a great day.